In the Second World War, the United States Army evacuated more than 14 million soldiers through its medical system. Of those, more than 97% who reached a forward aid station alive survived to the end of the war. No army in history had ever done that before, and almost none of the men who made it possible are in the history books. On the morning of the 10th of July, 1943, a 24-year-old medical officer named Henry Beecher crouched behind a low stone wall on the southern coast of Sicily and watched the first wave of American infantry come ashore under German artillery fire. He was an anesthesiologist from Harvard Medical School who had volunteered for the Army Medical Corps in the weeks after Pearl Harbor. What he observed over the next 6 hours would eventually change the way medicine understood pain, shock, the relationship between the human body and the will to survive. But that morning, what it meant was simpler and more urgent. Men were dying on the sand in front of him. The story of how the United States built that medical system, what it could do by the time it reached Sicily and then Normandy and then the Rhine, is one of the least examined achievements of the entire American war effort. It happened because a collection of physicians, administrators, logisticians, researchers, most of them civilians who had never worn a uniform before 1940, spent the years between the fall of France and the invasion of North Africa doing something that armies had almost never done before. They planned not for the battles they hoped to fight, but for the casualties they expected to receive. The man who drove most of that planning in the early years was not a general. He was a surgeon named Norman Kirk, who had served as an Army orthopedic surgeon in the First World War. Kirk was appointed Surgeon General of the United States Army in June 1943. He believed that the primary cause of preventable battlefield death in the First World War had not been inadequate surgery. It had been inadequate transportation. Men had bled to death, or gone into irreversible shock, or died of wound infection not because the surgeons at the base hospitals could not help them, but because it had taken too long to move them from the place where they fell to the place where the surgeons were waiting. Kirk's determination to do something about it at an organizational scale that the peacetime Army had never attempted transformed the Medical Corps entirely. The Army Medical Corps in 1940 consisted of fewer than 1,200 commissioned physicians and surgeons for an active-duty military force of roughly 267,000 men. By the end of 1944, the Corps had expanded to more than 47,000 medical officers, supported by more than 600,000 enlisted medical personnel, operating across every theater of war the United States was fighting in simultaneously. By 1943, approximately 1 in every 3 American physicians was in uniform. The physical infrastructure that supported those physicians grew at a pace that has no real comparison in the history of medicine. The Army built or requisitioned more than 700 hospital facilities outside the continental United States alone during the course of the war, with a combined bed capacity exceeding 570,000. Inside the United States, the network of general and convalescent hospitals reached a total capacity of more than 700,000 beds by the spring of 1945. Facilities with operating rooms, laboratories, blood banks, dental clinics were constructed on a schedule that civilian hospital building programs of the era would have considered impossible. The system through which a wounded soldier moved from the front line to one of those hospitals was organized around what the Army called the chain of evacuation. It operated in stages. The first link in that chain was the battalion aid station, typically set up within several hundred yards of the front line, staffed by a medical officer and a handful of enlisted aidmen, equipped to provide immediate treatment for shock, hemorrhage, and wound contamination. Enlisted soldiers who had completed a 10-week medical training course operated under fire, in conditions that resulted in one of the highest casualty rates of any non-combat specialty in the Army. By the end of the war, more than 2,700 Medical Corps aidmen had been killed in action. From the battalion aid station, the wounded man moved rearward through a collecting station, then to a clearing station, and depending on the severity of his injuries, either to a field hospital capable of performing emergency surgery or directly to an evacuation hospital located further behind the lines. The field hospital was the most important surgical unit in the forward chain. Its design had been substantially revised between 1940 and 1942, based on the lessons the Army's medical observers had gathered from studying British and Commonwealth casualty treatment in the Western Desert and in Malaya. The platoon system divided the field hospital into 3 self-contained surgical platoons, each capable of operating independently, leapfrogging one another as the front advanced, maintaining continuous surgical coverage without any of the gaps that had cost lives in the earlier configuration. One of the developments that made the most difference was the systematic use of blood transfusion at the forward surgical level. In the First World War, blood transfusion had been understood as a treatment for severe hemorrhagic shock, but it had been administered inconsistently, in small volumes, almost always too late to affect the outcome for the most critically wounded men. Whole blood could not be stored for more than a few days under refrigeration. The Army Medical Corps began working on this problem in 1941. By the time American forces landed in North Africa in November 1942, it had established a blood procurement and distribution system capable of delivering refrigerated whole blood from collection centers in the United States to forward surgical units in theater within 72 hours. The Army Blood Program, administered through the American Red Cross, collected more than 13 million units of whole blood from American civilian donors between 1941 and 1945. Plasma presented a different and in some ways more tractable problem. Dried plasma, which could be reconstituted with sterile water and administered without blood typing, had been developed by researchers at Columbia University in the late 1930s. The Army adopted it as a standard item of medical supply before the United States entered the war. By the time of the North African invasion, it was available at aid stations and collecting stations throughout the theater. A wounded soldier in severe hemorrhagic shock who reached a battalion aid station in 1944 could receive plasma within minutes of being examined. His counterpart in 1918 would have waited hours, and many of them had not survived the wait. The Army's own analysis, compiled in the post-war medical department volumes, attributed a measurable reduction in shock-related deaths at the battalion and regimental level directly to its routine availability. Sulfonamide drugs, and, from 1943 onward, penicillin, completed the frontline medical picture in a way that no previous generation of military surgeons had experienced. Wound infection had been the primary cause of death among soldiers who survived initial injury in every major war before 1940. In the American Civil War, roughly 1 in 4 soldiers who underwent a major limb amputation died of infection afterward. In the First World War, with the introduction of antiseptic technique and more aggressive wound debridement, that figure had improved. But gas gangrene and septicemia continued to kill men who had survived surgery. In the Second World War, the Army Medical Corps introduced the routine application of sulfonamide powder directly into wounds at the point of first treatment. Combine D with oral sulfonamide tablets carried by every soldier as part of his individual equipment. The result was a reduction in wound infection rates that the medical department's own historians described as the most consequential single change in battlefield medicine since the introduction of antiseptic surgery. Penicillin's arrival in the theater supply chain in 1943 extended that advantage further than sulfonamides alone could reach. The drug had been identified by Alexander Fleming in 1928. And developed into a clinically usable form by Howard Florey and Ernst Chain at Oxford in 1940 and 1941. The American pharmaceutical industry, coordinated through the Office of Scientific Research and Development, and a network of contracts with companies including Merck, Pfizer. Squibb increased penicillin production from a few hundred million units per month in early 1943 to more than 646 billion units per month by the end of 1944. Military allocations received priority throughout. By the summer of 1944, penicillin was available at field hospital level across both the European and Pacific theaters. The Pacific theater presented a medical challenge that differed from the European in one fundamental respect. Disease, not enemy action, was the primary cause of non-effectiveness among American troops throughout most of the Pacific campaign. Malaria alone rendered more American soldiers temporarily unfit for duty in the Southwest Pacific during 1942 and 1943 than enemy fire. On Guadalcanal, the ratio of malaria casualties to battle casualties at certain points in the campaign exceeded 5-to-1. The Army's response to this required the coordination of preventive medicine, entomology, engineering, supply on a scale that the pre-war Medical Corps had not been designed to support. Became the central instrument of malaria suppression, administered on a mandatory daily basis throughout affected theaters. The discipline required to enforce that mandate against a drug that had significant side effects and was widely rumored among the troops to cause permanent damage, occupied a substantial fraction of the energy of forward medical officers throughout the Pacific War. The neuropsychiatric casualties of the war presented a challenge of a different kind. The Army had been broadly unprepared for the psychological consequences of sustained combat. By the end of the Tunisian campaign in May 1943, psychiatric casualties were accounting for a significant fraction of all hospital admissions in the theater. Senior commanders, including George Patton, had begun pressing for the evacuation of men classified as psychiatric cases to cease entirely on the grounds that it rewarded cowardice. The confrontation between that view and the medical evidence was direct and sometimes explosive. The Army's solution, developed largely by a psychiatrist named Roy Grinker and his collaborator John Spiegel, was to treat acute combat stress as close to the front as possible, with rest, food, sleep. Brief supportive therapy, rather than evacuating men to base hospitals where the distance from their units reinforced the psychological break from combat identity. The forward treatment model reduced the long-term evacuation rate from psychiatric presentations substantially in those units where it was applied consistently. Henry Beecher, who had begun the war watching men come ashore at Sicily with his notebook, ended it having written one of the most important papers in the history of pain research, working from his observations of severely wounded soldiers at multiple points in the Italian campaign. He documented something that surgeons at aid stations had noticed informally but had not systematically recorded. Men with objectively severe wounds, including compound fractures and penetrating abdominal injuries, frequently reported little or no pain in the immediate aftermath of wounding and required far less morphine than civilian surgical patients with comparably traumatic injuries. Beecher's interpretation, published after the war, was that the meaning a wounded soldier attached to his injury, specifically the knowledge that it meant removal from danger and return toward home, altered the subjective experience of pain in ways that had no physiological explanation available at the time. The paper appeared in 1946 and became one of the founding documents of what would later be called psychosomatic medicine. By the time the German surrender was signed at Reims on the 7th of May 1945, the Army Medical Department had treated more than 17 million individual cases of disease and injury across all theaters of the war. Battle casualties totaling 234,874 killed in action were accompanied by 565,861 wounded in action, of whom the overwhelming majority survived their wounds and returned either to duty or to the United States for further treatment and rehabilitation. The wounded survival rate of better than 97% for men who reached medical care alive was a figure that Army Surgeon General Kirk cited repeatedly in the post-war years when the question was asked how it had been accomplished. His answer was always the same. It had been accomplished because the planning had been done before the shooting started. This was because the system had been built large enough to absorb what actually happened rather than what had been hoped for. Because the men who carried the wounded off the beaches and out of the hedgerows and down from the ridgelines had done it under fire, without hesitation, for the length of the entire war.